You're listening to Just Medicine, an equity in healthcare podcast created by medical students in British Columbia.
Hello, everyone. Welcome back to the Just Medicine podcast. My name is Zoe, and I'm going to be your host today. I would like to introduce our guest, Dr. Mary Kestler, and I'll give a short introduction before we begin our conversation. Dr. Kestler is an infectious diseases specialist with particular expertise in HIV, TB, global health, and tropical medicine. From 2008 to 2012, she lived in Botswana, where she served as a TB HIV advisor to the Ministry of Health and helped to develop the Department of Medicine at the University of Botswana Medical School. Today, she works in Vancouver at St. Paul's Hospital, BC CDC TB Services, and the Oak Tree Clinic, a provincial referral centre for women and children living with HIV at BC Women's Health Centre. She is currently the immune system lead for the UBC Medical School, where she develops and teaches the infectious diseases curriculum. In 2020, she was awarded the UBC Faculty of Medicine Clinical Faculty Award for Excellence in Clinical Teaching. I am very grateful and honored to have Dr. Kestler as a guest on the podcast today and look forward to addressing the many intersectional qualities that HIV has. Okay, so thank you so much for joining me today, Dr. Kestler. How are you doing today?
I'm great. Thanks so much for inviting me to be here.
So I'm super excited to discuss a lot about HIV with you. But just to start off, I want to ask you just a few personal questions and just let the audience, get introduced to you. So first of all, can you just tell me a bit about the path that you took to get where you are today?
Yeah, I definitely can. I'll try to make it short so we have time to talk about other things on the podcast. Let's see. I am originally from the United States, so that's where I did medical school and my internal medicine residency and also infectious disease fellowship at University of Colorado. And when I finished that, I went to Botswana and worked there for 4 years doing TB and HIV work. I was working for University of Pennsylvania, but it was funded through a combination of the Bill and Melinda Gates Foundation and uh, Merck Pharmaceuticals, which and the government of the United States, which you may not remember this, but there was a huge program back right around 2004 called PEPFAR, which is the President's Emergency Fund for AIDS Relief. And that basically funded millions of dollars to sub-Saharan Africa and the Caribbean to address the rollout of antiretroviral therapy for HIV. And I do a lot of TB and HIV work, a lot of public health, but also a lot of clinical developing the MDR-TB treatment program for the country with colleagues, working with the Ministry of Health on guidelines, et cetera, lots of stuff. And also University of Botswana was starting a new medical school at that time, which was really exciting. So I had an opportunity to work with their faculty and students to develop that program. And then we decided to leave Botswana, and we came to Vancouver largely just because Vancouver was really a center for HIV excellence in the world, and that was my area. And also, I think we were interested in continuing to work outside the United States, mostly because we were committed to a national health service program, which is not available south of the border at this point. So we came here in 2012, and I started work at the Oak Tree Clinic, which is the provincial referral center for women and children living with HIV. It's located at BC Women's Hospital in Vancouver, and I've been there ever since. It is, yeah, very rewarding work. I also do about 20% of my time at St. Paul's Hospital on the infectious diseases consult service there, and I also work at BC CDC in the TB services, TB clinic. So it can be overwhelming sometimes, but yeah, no, it's great. So that's how I got to where I am today.
Okay, wow. That sounds like such an amazing story. Thank you so much for sharing that. I'm really interested to know what is a typical day in your life as an infectious disease specialist. I mean, I know that you just mentioned multiple different sort of avenues, but if you could just give a brief, typical day in your life, that would be amazing.
Yeah, sure. I mean, I guess there's two different types of typical day. There's the typical day that would be in the ambulatory setting, and then there would be the typical day in the inpatient wards. And I guess with the ambulatory setting, a typical day would be get to Oak Tree in the morning, see patients all morning long. Maybe at noon, if I have some teaching that I need to do with UBC, the medical students, or with residents, maybe some teaching. And then on once a week, I go to TB services in the afternoon. I'm either at Oak Tree in the afternoon or TB services, seeing patients there. And the life of an academic physician is always fitting everything you possibly can into the cracks while maintaining, close to 100% clinical schedule. So it means, teaching on your noon break. It means working on, a paper after work or after you put your kids to bed, or yeah, just trying answering your email, maybe once every few days, and training the people in your life not to expect you to have quick email responses. That's that. I guess that's it. When I'm on the inpatient service, things are a little bit more streamlined because all you really have time to do is see patients in the hospital and work with the fellows, residents, and medical students to take care of them. And so it's literally get to the hospital in the morning, start taking consults, see people all day long, kind of wrap up hopefully by 5 or 6 o'clock so you can go home and take care of your family. So yeah, that's kind of what a typical day looks like. A lot of patient care. I guess that's the real bottom line, is lots of patient care with trying to fit in teaching and research and other policy work or whatever, trying to fit that in the cracks. And then also just trying to be a sane person and take care of my family and my kids and all that too. So it's a lot. It's a busy life.
Right. Yeah, well, it sounds super busy, but I'm sure also super rewarding.
Yeah.
I do want to know about, what populations do you typically work with then, and sort of your different avenues of work? And, what are your why were you so specifically interested in going into HIV work? I guess those are two sort of separate questions, but if you want to start with the first one.
Sure. I mean, I guess they're really related for me, is that when I went to medical school, I went to medical school with a social justice framework for myself. I could have gone into law school, I could have gone into writing and journalism. I was a political activist back when I was in college. So for me, medicine was the way, the process by which I was going to um, work with underserved communities and try to basically improve the overall equity in society. So that was my choice going into medical school. And I was thinking I was going to do obstetrics and gynecology, but it turned out I actually didn't like delivering babies as much as I had anticipated. So I didn't end up as an OB-GYN. I went into internal medicine because of the incredible intellectual, it just felt like home to me, the thinking process and the intellectual aspects of it. And when I went, I actually wasn't planning to do infectious diseases in the beginning because I didn't think I needed to do that in order to work with underserved populations I was doing a lot of global health work at that time. And I was thinking, I could do that as well as an internist as I could as an ID specialist.
Mm-hmm.
But I ended up having some mentorship from some people at University of Colorado that really kind of steered me in the direction of doing ID. And I think when I went into infectious diseases, my goal was I wanted to study one or more of the big three. And when I say the big three at that time, what that was malaria, HIV, and tuberculosis. So
Mm-hmm.
the three big infectious diseases that are the cause of a tremendous amount of mortality in the world for people. And it turns out that Colorado was a real place of expertise for tuberculosis and also for HIV, but definitely for TB. I mean, when people think about the United States as centers of excellence for tuberculosis, Denver, Colorado is high, very high on that list, if not at the top of the list. So I was really lucky to be able to study there. So TB and HIV, that's why I chose that, is because it was the way I could become the most effective in helping people. in the realm I was working in at that time, which was, I had done a lot of work in Haiti and Tanzania and then Rwanda, and then finally landed in Botswana for 4 years. So
Mm,
it just seemed like the right way to prepare myself to be the most effective.
yeah.
So, yeah.
Okay, well, I think that's a great segue. I think we can move to talking a bit more about specifically HIV. And so, maybe just for the listeners who are unfamiliar, would you mind giving a quick overview of the natural history of HIV in those that it affects?
Oh, sure. Yeah. So, put simply, HIV is a virus that infects the CD4 T lymphocytes. It infects a few other cells, but really the CD4 T lymphocytes. And over a long period of time, it results in mortality of that cell population. Um, and when you deplete your CD4 lymphocytes, you lose kind of the general and the cell mediated immunity army.
Mhm.
And so you you become at risk for opportunistic infections that would not be affecting someone who had a normal immune system. So when someone is first infected with HIV, the first thing that happens is they have a very high viral load. So the amount of HIV in the blood goes sky high, like over millions of copies. And the CD4 count, the T cell, CD4 T cell count drops. And within a few weeks to a month or so of the initial infection, and people can get quite sick. Sorry, people can get quite sick with the seroconversion illness when their viral load is that high. But within weeks to months after the initial infection, the body's immune system controls the HIV. It gets control of it. And the CD4 count goes up, the viral load goes down to a particular set point. And the set point is different for everybody. And it's kind of the balance between the host's immune system, the strength of the host's immune system, and the pathogenicity of the particular HIV strain you're dealing with. And so the set point could be 20,000 copies for some people, it could be 5,000 copies for another person. Some people have a set point that is an undetectable viral load in the absence of HIV medication. We call those people long-term non-progressors. So but during that period of time, after the body's immune system gets control of the HIV, you can go for 5, 10, 15, 20, even more years where you're asymptomatic and the person has no idea that they're living with HIV. And if they haven't been tested, they may be transmitting HIV to other people if they're not in treatment. So then, but for everybody, at some point, the CD4 count drops below a critical threshold, which we say is about 200 cells. And after that point, people are quite at risk for opportunistic infections, pneumonias, meningitis, um, other infections. And one below 100 is another critical threshold. Below 50 is another critical threshold. But eventually people die because they will, and they die because of either an HIV related infection or malignancy. And yeah, that would be the natural history of HIV. One thing I just want to say about that, though, that's important is the reason we can't cure HIV right now is because very early on in infection, resting memory T cells are also infected with HIV. And you can think about it as HIV just kind of curling up in the DNA of those cells and going to sleep. It's not replicating. And it stays in the body then for decades as a reservoir. And until we can figure out a way to wake up that reservoir and kill it and clear it from the body, we're not going to be able to cure HIV.
Okay, that's really interesting. I actually wasn't really aware of why we really couldn't find the cure as
Mm.
of right now. I do have one question. So, when you were mentioning treatment for HIV, what is the current treatment protocols for patients with HIV?
Yeah, so I've been a doctor for enough time now that I have lived through. When I was in medical school, we just had developed the first effective regimens for HIV. So you'll recall in the early 90s, we only had AZT, we had lamivudine, we had danosine, just a few drugs that we knew worked, but we didn't know whether we needed to use one at a time, two at a time. Nobody suppressed in the early days. Nobody had viral suppression in the early days. And It wasn't until 1997 that we developed, 1996, 1997, that we developed the protease inhibitors. And then we learned that if we put protease inhibitors together with two other drugs for a combination of three medications or highly active antiretroviral therapy, that people would suppress their HIV and they would live. And that was an absolutely critical moment because we went from HIV being a death sentence to HIV being something people could survive and live with. Now, the problem was is that even in those early days, really up through, I would say, 2008, 2009, there were still just tremendous side effects with the medication, and people were having to take very high pill burden regimens. So 2, 3, 4, 5 tablets, maybe even more a day, sometimes 2, 3 times a day, really difficult. And there were a lot of very unhappy side effects with those medications. And people were still had a lot of resistance developing. And so we then finally, towards the middle of the around 2005, we developed the first single tablet regimen for HIV, which was a tripla. And that pill really changed things for people because it made HIV easier to treat and take, one pill a day as opposed to 10 pills a day, and it was reasonably well tolerated. And that is really, since that time, all of our efforts for HIV treatment have been about making it easier and safer for people to take medication. We know how to suppress the virus. We know how to do that really well. We've known that for decades now, since HAART, in the post-HAART era. But the medication is not, we need to get regimens that are as easy for people to take as possible. And what we're hoping for on the horizon is injectable depot medications that people can take, an injection once every 6 months or maybe once a year. And that's how they would treat their HIV instead of even having to take a pill once a day.
Wow. So the tripla medication that you mentioned, is that just three of those sort of antiretroviral therapies in one? Is that what they did?
That's right. And so pretty much all the standard regimens for HIV now are a single tablet regimen, meaning you have 2 to 4 medications in a single tablet that you give to people. So it's quite easy to take.
Mhm.
Um, but a triplet was the first. That was the very first one, and it had 3 drugs inside of it: efavirenz, tenofovir, and emtricitabine. And it was such a game changer. And I was working in Botswana at that time. And you can imagine how great that was to have a single tablet that people could take, who are living in very rural areas and living in very difficult circumstances. It's much easier than having a regimen 3 times a day with maybe, you know, 4 to 10 pills that you have to take.
Yeah. Yeah, I think that's actually a perfect link to sort of my next question. So, moving more into talking about the social determinants of health and their kind of intersection with HIV. So, we know that there's been a lot of papers that have discussed, how interwoven these two things are and how poverty, social vulnerability are strongly associated with a higher burden of HIV. So, can you provide a little bit of your perspective on how the social determinants of health are interwoven with this disease?
So, I mean, I guess the first is how social determinants of health increase the risk for people acquiring HIV in the first place.
Hmm.
And I think that the main factor there is that when people are living with extreme poverty, or maybe are living with severe drug addiction, or are hungry and don't have enough food to eat, women, but men too, will engage in sex work or will engage in risky sexual practices in exchange for food, drugs, money, safety, even. And so that's a major risk factor for HIV.
Hmm.
Um, once someone has HIV, the social determinants of health are extremely important because in order for somebody to make doctor's appointments, go to a lab, take medication, go to a pharmacy, pick up medication, take a medication every day, you have to there's a lot that goes into that. And there are a lot of barriers that can keep people from taking their medication, because essentially what we're looking for is we want people to take their medication so that their viral loads are suppressed, so that they can live long and happy lives, or healthy lives, and we can reduce the transmission of HIV. That's the overall goal. But to get people to that goal, there are a lot of different barriers in place. So for example, cultural or language barriers are huge. People have to understand what HIV is in the first place. They have to understand, because a lot of times when you're starting people on medication, they feel fine. They've been diagnosed with HIV, but they're in that long latency phase and they feel okay. So why should they take medication? Um, and also people may not speak the language. So has the information been explained to people in a language that they can understand? Has the information even been given to them in a
Mhm.
way that they
Mhm.
can understand, even if they speak the language? So I
Mhm.
mean, there are culture, language, educational barriers. There's, you have to have money to be able to take the bus to get to a clinic to see your doctor. You have to know how to use public transportation. You need to know, if you're disabled, for example, differently abled, is there an elevator that you're going to be able to use, or is there only is the clinic itself accessible?
Yeah.
What about women who are maybe working 3 jobs to try to support, their children? Maybe they're single moms. What about childcare? Can they get childcare when they come to a clinic? Or um, can they take time off of work to be able to come to a clinic appointment? So there's all these things that like get in the way. And then, do people have enough food to eat? Because sometimes you have to take medication. Some people need to take food with their medication. But if you don't have enough food to eat, or your food is very erratically available, you may not be able to take your medication properly. So I mean, I could keep going on and on. There's just a million barriers. Sometimes it seems like a miracle that people are actually suppressed in the first place. But yeah, all of those things are major barriers.
The next question I have revolves around two specific social demographics who have had a particularly high prevalence of HIV infection. And these are men who have sex with men and also people who use injected drugs. Can you touch on how you feel these groups have been individually affected by HIV?
Sure. And let's be clear that in British Columbia, the the highest prevalence in incidence, and when I say incidence, I mean number of new diagnoses or new infections in a given period of time. Usually it's a year.
Mm-hmm.
And prevalence is all the number of people that are living with that disease at a point period of time. So the incidence and prevalence of HIV in British Columbia and in Canada is largely concentrated in the population of men who have sex with men. So that's the case. And that's the case in North America. That's the case in Europe, Australia. Around the rest of the world, it's a very different dynamic. There, it's much more of around the world, it's much more of a heterosexual epidemic. But yeah, in Vancouver back in the 90s, we had very high rates of HIV within the injection drug using community, very high rates. And it was a huge thing for Vancouver to develop needle exchange programs, some of the first in the world. Mobile vans that went around doing needle exchange for people. We have the first injection, the first safe injection site in
Mm-hmm.
BC. It was a lot of our harm reduction policies, also transitioning a lot of people who were using injection drugs onto methadone, and then being able to link the methadone to their daily HIV medication with direct delivery. There have been a lot of things in the harm reduction universe that has really dropped the rates of HIV in the community of people who inject drugs. So that's changed a lot. Um, Overall, the incidence in British Columbia, overall, the incidence of HIV has been declining year after year for decades now, which is great.
Mm-hmm.
Uh, and some of that is because we have probably the single biggest reason for that is because we have such a great drug treatment program here. It's centralized. We have very high rates of people who are infected with HIV, who know their diagnosis, who are on treatment and virologically suppressed. And if you can suppress people, it's what we call treatment as prevention.
Hmm.
So it leads to a dramatic decrease in number of new infections. Now, we were talking about Vancouver versus the rest of Canada, or thinking about Canada as a whole. Really, the highest rates of HIV right now are in Saskatchewan. And it is in people who inject drugs, but also the heterosexual population. So the rates right now, the rates in Saskatchewan, I want to say they're at least 10 times, if not more, higher than the rest of the country.
Okay. I also wanted to ask, about giving those preventative pills that you were mentioning. How has that been altered, or how has it evolved to address the needs of the patients who do maybe have substance use issues and who may have higher rates of infection in our community?
So, what I was saying originally is for people who inject drugs, the biggest intervention to prevent the transmission of HIV is, I'd say, twofold. One is the provision of safe supplies
Hmm.
so that nobody's sharing needles. And um, yeah, that's that. And then the other thing is reducing the viral load in the overall population so that even if you don't use a clean needle and that you're using with someone who's HIV positive, that the person you're using with is on medication for HIV and their viral load is undetectable, your risk of transmission is very low, if not zero. So that's really the prevention. The treatment is prevention, and then safe supplies. Those are the two big things for people who inject drugs. Now, for men who have sex with men and for the population men who have sex with men, one of the biggest factors besides treatment is prevention is the the use of a single tablet called Truvada, which is a combination of tenofovir and emtricitabine. And this is what we call PrEP, or pre-exposure prophylaxis. And people can take one tablet a day, and as long as they're taking it, it dramatically reduces their risk of acquiring HIV from a sexual exposure.
Hmm.
We have a lot of different good treatment or prevention options, but the single most powerful one is to get as many people as possible on treatment.
Right. Okay. Thank you so much for your answer. That was really great. Um, Social stigma is another challenge that individuals living with HIV continue to face. So, can you provide an overview of how you think HIV stigma affects your patients and also how this may have evolved over time?
Okay, I could have an entire podcast just on this subject alone
Hmm.
because this is absolutely huge. Even in an era when we can treat HIV with a single tablet, where people can have a life expectancy that is very similar to what people who do not have HIV have, where we have treatment as prevention and people can have very healthy sex lives and have children without having to worry about transmitting HIV. I mean, that's the universe we're living in. And there is still tremendous stigma related to HIV, and that stigma kills people. And so, what does that look like in the life of the people I work with? Well, it means that anybody who is living in a small town or a rural area may be terrified of going to the pharmacy or going to the lab because they'll meet somebody that they know. Maybe the person who's drawing their blood at Life Labs is their neighbor. Or maybe they go into a pharmacy and the pharmacist takes their medication out and talks at the top of their lungs about, oh, do you know what this is for? And what kind of medication is this? And, this is for HIV. And all the people standing in line behind them then know that person's HIV status.
Hmm.
The opportunities for disclosure of HIV are tremendous, and people live with that fear every day. For women in particular, the silence around HIV and not having people that you can share that diagnosis with, talk about it, and get support from is devastating. It leads to a tremendous amount of shame and isolation, and that has terrible health outcomes for people. Um, I have, I've had patients of mine over the years who have died of an overdose or a suicide with an undetectable viral load. So, meaning they're on their HIV medication and they're suppressed, but
Mhm.
some aspect of stigma related to HIV and what that has done to them in terms of their social relationships and their sense of themselves has led to an overdose or suicide. So you see, the stigma itself, despite the biological realities of HIV, the stigma itself is devastating for people and it kills people.
Mhm.
So those are just some examples, but I have more.
And I really liked how you touched on how women do face some unique challenges with HIV. So I wanted to ask a bit more. I know you work a lot with women and children with HIV. So how do you think HIV affected women? How do you think their outcomes are different in terms of their diagnosis, their treatment, the stigma they face, the situations they may find themselves in with HIV?
I think that one of the probably the most profound difference is that women are more likely, and I'm going to say this for at a global level,
Hmm.
but women are more likely to be impoverished women than men.
Hmm.
Women are more likely to be paid lower amounts of money for work that they do, for harder work that they do than men.
Hmm.
Women are far more likely to be supporting children and other family members as part of their responsibilities. Women also, in many areas of the world, do not have access to education and power, financial and educational power, and political power the way men do. And all of those things combine to make women have to make very difficult choices. Let's say a woman is not even infected with HIV yet. It gets back to what we were talking about earlier with, does a woman need to engage in risky sexual behavior that could lead to her acquiring HIV because of the need for money, the need for cell phone minutes, the need for food, the need for drugs if she's addicted? And so that's one thing. There's also, we haven't even talked about the whole issue of intimate partner violence for women and women's ability to control their reproductive power and freedom makes a big difference. There are women in my practice who are engaged in sex work but are not able to use a condom, or women in relationships who do not have the ability to set the terms of their sexual relationship with a man. So
Hmm.
all of those things really matter. Yeah, I think that that's one of the ways that things are different for women. But I think it's also, again, the sharing, having to care for families, children, working multiple jobs. Those things really get in the way of people's health. And this is not just for HIV, it could be for high blood pressure, it could be
Hmm.
for diabetes. Women are just not, women who are struggling to make ends meet and are exhausted at the end of the day after working, 2 or 3 jobs, maybe as a care aide or a cleaner. Just the priority of taking medication and taking care of her own health is not what we wish it would be.
Thank you very much for giving your perspective on that. I also want to ask, from a clinical side, as someone who does care for people who may be facing all these challenges, can you discuss the importance of trauma-informed care in addressing the needs of women living with HIV?
Absolutely. So, the one thing that I would say, I have a very diverse patient population,
Mhm.
but what I would say the one factor that underlies everything, besides being HIV positive, is a history of some trauma in the background. And that trauma could be, and is usually, some adverse childhood events. It may be sexual violence. It often is sexual violence. Um, and that trauma, together with either stigma, discrimination, um, possibly addiction, these things can really impact the health of someone across the board as adults. I think we know that. That's well shown in research studies. When people are traumatized, especially as children, and it's deep back, and they may be living with some post-traumatic stress disorder, or even if it doesn't meet the clinical criteria for PTSD, their behavior, their reactivity, their way of relating to other people and the world around them is different. It changes. And they may be easily triggered by certain things that other people wouldn't be. Their like fear may come out in ways that um, can be difficult to interpret for healthcare providers. So I'll give you an example. Many of my patients have a fear of the hospital. I mean, for heaven's sakes, I have a fear of the hospital. I don't want to go in the hospital myself. But, many people have fear of hospitals. And some of that may be because of stigma and discrimination they've experienced at a hospital. It may be because they spent too much time in a hospital as a child, maybe with a mother who was suffering from intimate partner violence. It may be because the institution, it's a Catholic institution, and that has a whole um, that is a whole meaning for Indigenous people in this country. There's all kinds of things
Mm-hmm.
that can make people not want to go to hospital and be deathly afraid of it. And what that looks like to us as healthcare providers is, well, what do you mean with this pneumonia or this cellulitis or this infection that you don't want to go to the hospital? Are you kidding me? You're likely to die. But the
Mm-hmm.
patient isn't going to go to hospital, and they're going to get upset and angry when you're trying to press them to do so. So that is all a trauma-based response. And yet we don't see it as healthcare providers because we never had that experience ourselves. So trauma-informed care to me is a healthy appreciation for what people have gone through in their lives. And even though I may not have experienced it, I have an imagination, and I can imagine it, and I can listen to the stories that other people have told me, and I can see how it shows up then in their adult behavior. And so rather than judging them for that adult behavior, I can see it as a response, and in many ways, a very healthy adaptive response at the time,
Mm-hmm.
to trauma they experienced long ago. And once you have that mindset, you just approach people very differently.
Yeah, I'm honestly really enjoying listening to you. And I'm really hoping that this perspective, anyone listening, they can take this on as well. Because I think, as healthcare providers, it's so important that we do take a trauma-informed approach with all these different people, and everyone has a different story, and that background can present so many different ways, as you said. So, yeah, very important. Slightly related, in your practice, can you share any specific examples of harm reduction strategies or recommendations that you give to patients to support those with HIV who have complex needs or have gone through trauma?
I would say, well, we'll keep with the hospital example for the moment.
Yeah.
Would say that one of the things that's really important is that when patients of mine do not want to go to the hospital, I would say that's the majority, but
Mhm.
yet I know that they need to go to the emergency department. They need to go into hospital, but they just won't go. And I'm talking about for really severe infections like infectious endocarditis or bloodstream infections or terrible osteomyelitis that is really on the verge of amputation, and people will not go into hospital. One of the things that we try to do, first of all, you hear people out, you meet them where they're at. And if they understand what the risks are and they are freely choosing not to go, then what I try to do is I try to set up strategies to diagnose them and treat them outside of the hospital with the support of social workers, outreach teams, maybe their family physician. There's all kinds of things that you can do to mitigate the damage. Even though the ideal situation is to admit them to hospital, you can work with their pharmacy to set up a direct observation and delivery system of medication. Maybe you choose to use an oral antibiotic rather than an IV antibiotic, even though you know that your teaching in medical school and fellowship and residency was that you should use an IV antibiotic. But okay, you're not going to get an IV antibiotic in this patient. So we're going to do the best we can with the best oral antibiotic, with the best daily distribution we can get. And then we're going to get the outreach team or the outreach social worker to check in with the patient every couple of days to make sure that if things are really getting worse and the patient is getting really sick, that somebody is watching over them and is able to maybe bring them to hospital at a later date. That's just an example, but it's like that's one of the ways. And you don't say to the patient, oh, well, you're not going to go to hospital, well, good luck with that. That's
Mm-hmm.
not the answer.
Mm-hmm.
The answer is, okay, I get it. My best advice is that you go to the hospital. But if that does not work for you, let's see what we can do to keep you safe and treat this infection over the next couple of weeks. And if that doesn't work, then we can discuss whether it's time to go to the hospital.
Mm-hmm. I'm just interested in a situation, as you were mentioning before, if a woman is facing intimate partner violence, they're being forced to not use a condom or they're being coerced. What would your recommendation be in order to sort of allow for harm reduction in that sort of standpoint?
Yeah, so there's two issues there.
Mm-hmm.
There's the issue of safety for her,
Mm-hmm.
and then if she's HIV positive, there's the issue of safety for her partner in terms of protecting him from getting infected with HIV. So the issue for the safety for her, if she is if she's not HIV positive and she's in a relationship with someone who is, say, HIV positive, known HIV positive, and she's not able to use a condom, she doesn't have that power in the relationship. One kind of creative strategy might be to try to see if you can engage him in any way. I would say, see if there's any possibility, like to engage him in HIV care so that he can start on HIV medication, so that at least if they're not using a condom, that he is undetectable and is not going to transmit to her. That's one strategy, is you kind of attack it from the side of the partner if you can.
Mm-hmm.
Um, Another option would be to prescribe for her pre-exposure prophylaxis. So she would have the ability to take Truvada on a daily basis to prevent herself from acquiring HIV. The other issue is if she's HIV positive and the partner doesn't want to use a condom, then the most important thing is getting her on treatment so that she's undetectable
Mm-hmm.
and so that she can not prevent. Now, there's a separate problem for people living with HIV in Canada, which we call HIV criminalization. The Criminal Code of Canada says that in order to not inform somebody that you have HIV, that you need to meet two criteria. You have to first be on medication and undetectable, and then you also have to use a condom. And many of us who work in the HIV field feel that this is really ridiculous and stigmatizes people, criminalizes people living with HIV, because if you are on treatment and undetectable, there is no added benefit of a condom to preventing HIV transmission. And that's in all cases, no matter what kind of sex you are doing, and no matter whether there are the presence of sexually transmitted infections. This has been very well shown
Mm-hmm.
that if you're undetectable, you are untransmissible. But the Criminal Code of Canada does not recognize that. So for a woman living with HIV to not tell a partner that she's positive, she would need to use a condom. So that's tricky. That's a really tricky situation, because if she doesn't want to tell the partner and the partner is insisting on no condoms, she is at risk. She's
Mm-hmm.
at risk if for whatever reason he ended up with HIV, it can become a real sticky situation. But the best way she can protect herself is to take medication.
Okay, thank you. That was a really good answer.
Can I say one other thing about that?
Please.
I guess the bottom line in all of this is that every single person is a unique story, and every single person should have a unique approach. There's no one-stop shop or one size fits all. That's the better way to describe. There's no one size fits all for people living with HIV. Not in terms of medication, not in terms of approach to care, not in terms of harm reduction. Everybody is unique, and the approach needs to take that into consideration.
Yeah. And along that line of thought, as you said, everyone is unique and there's a lot of complex factors that go into what HIV is. What can we do as students or just general members of the population to educate ourselves on HIV and also to advocate for those people who are affected by it and who are stigmatized by it?
Okay, the single most important thing that medical students and residents and physicians can do is first do no harm. The number of people who are living with HIV who have experiences of stigma from healthcare providers, it's almost universal, is terrible. We have got to educate ourselves to understand and be comfortable with you equals you. Somebody coming into clinic with HIV who's on treatment is not going to transmit HIV to you as a doctor. And I'll tell you, I just had a patient last week tell me a story that is so familiar to me by now. She's a new immigrant. She's getting her medical exam from a physician in BC, in Fraser Health. And she comes into the clinic to get her medical exam. This is a standard medical exam for any immigrant to Canada. It's a chest x-ray, it's some blood testing, urine test, etc. And the doctor has to sign off on her. And she comes into clinic, and as soon as they ask her what medications is she on and what are her medical problems, she tells them, and there's an immediate response. She gets moved out of an exam room into what is almost like a broom closet in the clinic, where she sits while other patients are in the clinic going into normal exam rooms. She is completely devastated by this experience because she knows why she's being put in the closet in this clinic instead of um, being treated like a dignified person, human being.
Mhm.
And that is the kind of thing. I know it sounds crazy, but
Mhm.
that is the kind of thing that goes on all the time. This fear of transmission, the fear of people living with HIV, the incredible stigma for healthcare providers, for medical students, residents, and physicians. I beg you to remember that a person living with HIV is a patient, is a human being. And gosh, if they're on treatment, there is no way you are at risk for transmission from that person.
Yeah, that's a really important message to kind of wrap this up. I do want to ask one more thing in terms of when medical students are on infectious disease rotations in general, not only will we be seeing, HIV, but any sort of infection, what would you give as sort of a last piece of advice along those lines of humanization? But I think on a broader scale, what would you advise us to keep in mind?
I think that is probably the most important thing, what I just talked about, is remembering the humanity of the person that you have the privilege to take care of.
Mhm.
I think, I guess from a more clinical standpoint, always make sure when you're in your approach to someone living with HIV that you know what their last viral load was, you know what their CD4 count is, because their CD4 count is going to tell you a lot about their risk of opportunistic infection. Make sure that if they are not on HIV treatment, that you do not lose the opportunity to encourage them to begin treatment and link them to a care provider in their community, whether it's a family physician or an HIV specialist, somebody who can get them started on treatment. um, don't ever lose the opportunity to diagnose somebody with HIV. You should know the HIV status of every single patient in your practice. And there are guidelines for this in British Columbia that everybody, you should know the HIV status of everyone. And there are certain high risk groups that need to be tested more often. So don't lose the opportunity to make the diagnosis. Don't lose the opportunity to talk to someone with compassion, meeting them where they're at, with understanding, and in a trauma-informed way, but encouraging people to get on treatment and to
Mhm,
protect themselves.
mhm. Well, thank you so much. I think that's all my questions. Do you have anything else you want to add?
No, I think that's great. Thank you so much for having me and giving me the opportunity to talk about this stuff because it's not only close to my heart, but it's really, really important for the people that I work with and take care of.
Yeah, I think it's going to be really educational for people listening, and I'm hoping that we can maybe have you back another time to talk about another topic. But yeah, thank you so much for your time.
Absolutely. Thanks, Zoe.
Thanks for tuning in to Just Medicine.